We have our Four Nations Advanced Care Planning panel. It's going to be chaired by the fabulous Clare Fuller. We have available today from different parts of the world, well, the UK. We have Idris here, Idris Baker, representing, so I feel like in a boxing match, representing Wales, or whatever it is. So, and Idris is the National Clinical Lead for Palliative and End-of-Life Care in Wales. We also have Jenny, representing Scotland. She works for HomeFirst Design and is an implementation manager for NHS Scotland. Welcome, Jenny. And we have Lucy Payne, who is the strategic clinical lead for the Gold Standards Framework in England, representing England. Unfortunately, we had some sad news today that Corrina, who is coming from Northern Ireland, was not able to come today, but she has kindly shared a video which I'm going to play now, and then we can start the discussions. I'll hand over to you, Claire. Whenever you want, Claire. I'm handing it to you.
Thank you so much, Danny. So would you like to take your chairs? Otherwise, this could go horribly wrong. Thank you. Can I say also, Vicky, it makes me proud to be part of the NHS listening to you. So I had goosebumps. So you said thank you to everybody, and I'd just like to say it was a proud moment to be part of the NHS listening to you. Thank you.
I need about 10 seconds just to change the sound settings over.
What have I got to do in 10 seconds? I can sing the whole of that Carly Simon song, but that's more than 10 seconds. Have you made a pledge? So everybody here, we keep talking about making a pledge. We keep talking about making a change and making an action. Danny's created 2 fantastic walls out there. So rather than formal feedback, what difference is coming here going to make to you today? And we'd love to see your differences in the forms of a pledge. So Danny, there are 2 walls, aren't there? What will you do differently, and what are you going to pledge to do from attending here? And also, just to remind everybody that's using social media, whatever platform you're using, hashtag ACP Day 2025. So let's keep connecting with each other through that social media and keep sharing the words.
And on the live stream, if you can pledge as well. So on the live stream, guys, we'd really love you to put your pledges on, because what we're going to do is collate all the pledges from the walls and also from the live stream and create a bit of a collage there. So we really want to get as many pledges as possible, and hope you will come back next year, and we are going to actually hold you to your pledges. That is not a threat, it's a promise.
You've seen what happens on stage with the lasting power of attorney signing. You get put on stage. Danny, before we start, can I just check in what time we're going to be finishing so we can bring this in on time?
We have
50 past, I love that. Thank you so much. Thank you. So it's my pleasure, everybody knows me, my name is Clare, it's my pleasure and honour to be chairing this panel discussion this afternoon. And we're going to be focusing on planning ahead across our nations. And we've developed this in response, Danny, wasn't it, to feedback from last year. So in response to last year's conference. Now, we acknowledge the multitude of terminology. We've touched upon this already this morning. There's a multitude of terminology within healthcare systems and across the nations. We talk of advanced care planning, we talk of advanced and future care planning, and we talk of future care planning across our nations. So our discussion today will move beyond that terminology and focus on strategies and innovations that have impacted practices across the nation. And then, really importantly, what can we learn from them today? So joining me today, Danny, thank you for the introductions already. Just to remind everybody, we have Idris, then Jenny, then Lucy. Corrina, as we've said, is unable to join us. She is the Health and Social Care Consultant from Northern Ireland and an Atlantic Fellow at the Global Brain Health Institute. It's really important to all of us, that Northern Ireland still has a say, even though they can't be in front of us and with us on stage now. So Corrina has kindly provided a contribution from Northern Ireland and presenting the Northern Ireland perspective, and we'd just like to show that now at the beginning of the session before we start our session. So if it's okay with you guys, we'd just like to show that brief clip. Thank you. Sorry?
We're really keen to share with you our journey on the advanced care planning road here from a Northern Ireland perspective. And maybe a good place to start is our policy, which was launched in October 2022, called For Now and For the Future. And this policy outlines 4 key components with a number of elements that enable people to start wherever they wish in terms of their advanced care planning journey. It looks at clinical, personal, financial and legal aspects of advanced care planning. I know Clare was keen to understand about digital aspects and innovation, and within Northern Ireland, as at the end of May, all of our health and social care trusts will use one clinical record, and that will certainly help with the dissemination of care plans right across our health and social care system, with linkages into primary care and hospice and other care providers. So that's something very exciting that's happening just this month. When we were developing the policy as well, we were mindful that people are becoming more digitally enabled, and we needed a digital solution to enable people to start their advanced care planning, particularly for some of those interoperability issues that we know can be a challenge in transferring information. And so we commissioned an ORCA review to look at available applications or apps that people are currently using. And it was delightful then to meet James and the wonderful work he does in My Wishes, and to begin to localise some of his functionality within My Wishes to enable us to have a accredited app that we could offer to people as part of our advanced care planning offering. We're also conscious that people still do like pen and paper, and people have a cathartic approach to writing things down. So in terms of innovation in Northern Ireland, it might be the same in other jurisdictions. When a child is born, they get a red book, and in the red book details their weight and their height and any health issues they may have, their vaccination status, etc. And in theory, that continues with them until they're 18. And what we have developed is an amber book, amber to get ready. And what we would hope is that each adult over the age of 18 will have an amber book that reflects the advanced care planning policy. So it outlines the 4 components and the different elements, so people can begin to start their own advanced care planning journey from the age of 18. Our legislation is different here in Northern Ireland. We do have a Mental Capacity Act, which has been implemented in different phases. We do have provision within the Act for lasting power of attorney for LPAs. However, that part of the Mental Capacity Act has not been commenced as yet. So in Northern Ireland, no one can act as a legal health proxy within a Northern Ireland context. Proxy and decision makers are limited to finance and property here in Northern Ireland. So I think that's an interesting fact that sometimes people don't necessarily appreciate. I think, like us all, we all strive to reduce and tackle health inequalities, and within the policy we were really keen that we engaged far and wide, and we employed as accessible arrangements as possible to enable people to be part of the co-production, and obviously then to access the policy when it was actually launched. We published the consultation, for example, in 12 different languages. We used ISL and BSL sign language. We worked with people with learning disability to translate the policy into short YouTube clips, and this made it a very accessible product, not only for those with learning disability, but for our community at large. And I just want to share with you one of the engagement sessions and the power of engagement on how this influenced my own thinking. So working with the deaf community, you learn that the deaf community is not a homogenous group, that people have different needs. Simple things like that English isn't people's first language. If you're using ISL or BSL, English is a second language, and so with that comes challenges. And during a number of sessions, after a number of weeks and months working with people within the deaf community, one lady said to me, "Look, I don't understand this concept." So again, I was explaining what advanced care planning was and how it would be used in time if you don't have capacity. She says, "No, I understand what advanced care planning is, but I don't understand the concept in my world." She said, "No one asks me for my view or on my decisions when I have capacity, so I don't understand this concept of how this will come into play when I don't have capacity to make those decisions for myself." And for me, it was a really stark reminder of the inequalities and the barriers that people face particularly if they have disability or communication differences. So it's something that's really struck me at the time and stuck with me ever since. We do see advanced care planning as a public health issue in Northern Ireland, and before the policy was launched, our palliative care and partnership programme had advanced care planning underpinned by a public health approach as one of their 4 key priority areas. And so for us, it's about how do we enable communities and people to think about and plan for their own health, including advanced care planning.
Thank you. Okay, just going to shut that down. Thank you, Danny. So that's great. Thank you so much for showing that video. So I'm going to start off with a broad question for each of you. Sorry, I've realised that I'm slightly talking to you, so I hope you don't get crick necks there. So with this broad question, I'd like to understand a little bit more about planning ahead in each of your different areas. I've got the same question for each of you. How would you each describe the current state of play in your nation, and what are the key priorities for you right now? I'm going to come to you first, Lucy, if I may, with that one. Have a talk and see what happens.
How's that? There we are.
Fantastic. Thank you.
Ask again. Sorry.
So really broad and general, it gives you scope to fly with this. If you want to push your chairs back, I'm mindful that all of you are cricking around to me, so I don't want it to anybody. You can see I'm a nurse. I worry about people. How would you describe the current state of planning ahead in your nation, and what are the key priorities right now?
So I think, in recent years, I would say definitely advanced care planning is, widely accepted as good and normal, I would say. But it's chaotic. It's really, and I've particularly become aware of this through working with the Gold Standards Framework, is it's very variable throughout the country. And in some places there's virtually none. In other places it's very good. Everybody's using different tools, different IT systems. In some areas that's shared well, in other areas less so. So I'd say generally it's a bit chaotic. I think the overriding theme is a challenge with what I would describe as the quality of advanced care planning, in that it's generally quite medically driven. So the policy around it is fairly health focused and often prioritises things like avoiding inappropriate hospital admissions, that sort of thing. Whereas I think the general public and perhaps the social care sector be more focused on quality of personal care and people's personal values and the way in which they want to be cared for, which isn't quite so medical. And I think those two things are captured differently and at different levels of quality. So I think, to me, those are the priorities, is getting that quality better and getting information shared more widely with a more, it doesn't have to be the same tools, but it does need to be sort of accessible.
So a main comment on quality, that's really interesting to reflect back on that, and it's lucky I was going to come to you next, Idris, anyhow. So I know you're going to be interested to pick up on those themes. Well, I'm hoping you're going to be interested to pick up on that theme of quality from what I understand of your work as well. So the same question to you. How would you describe current planning ahead in your nation and key priorities, and potentially coming back to Lucy's point about quality as well? I know you feel very passionately about that.
Yeah, that's true. It's very much work in progress, I think, in the same way that it is in England. A lot of it happening, and we know that quite a bit of it is happening, but some real gaps, particularly in terms of data. So I can say I know a lot of it's happening, but how much and what is not as well measured as we would maybe like it to be. And some gaps certainly in the making available the products of that, the information that the products of what we're now calling future care planning. No one wants to get too theological about the exact terms, but that's just for clarity of understanding. The term we're tending to use my side of the border is future care planning. Making the information that comes from those maturing conversations available to the people who need to be making decisions. So, that's very much work in progress I think we've been guilty sometimes of letting the best be the enemy of the good and trying to pursue brilliant solutions for doing that, and because we're so busy trying to pursue brilliance, ending up with nothing. So we're trying to rejig that approach a little bit. But in terms of the quality, yeah, I mean, what we're really about as a national programme altogether, including in our work on future care planning, is trying to make it more value-based. And so when it comes to FCP, we're trying to get towards making sure that we don't just have, important as this is, FCP conversations happening, that we don't just have the information of from the products of those being available so that it can have real bearing on decisions that are made, but that is actually improving the outcomes and experience that people have. It would be tragic, it would be criminal, I think, if we were to improve outcomes in the sense of people being cared for in the place they chose to be. To choose an obvious example, if we didn't also find out whether that care was good. Because we could end up making things worse, and we could find out in 10 years' time that we had spent time and energy making things worse. So we're trying to do it in a way that actually gathers and integrates and links the right data so that we can know what effect that's actually having as part of a wider programme of value-based work.
So very data-driven and then very focusing on the quality. What impact is this work making as well?
What are the outcomes? What are the experience? Yeah. And the outcomes from the person's point of view, not the system's point of view. Yeah. This isn't for the system. I'm going to get very grumpy with hospital managers who tell me you should have done some FCP because then we wouldn't have to be having this person in hospital. No, that's not what it's for. It's for the outcomes for the person. So we've got a core outcome set. We've got tools that are capable of gathering the core outcome set. We need the digital architecture that will do that and will present it back to the system and can integrate it with data on the FCP activity.
Thank you. I know lots of people here will be listening and focusing on that word outcomes. Before I move on to Jenny, can I just ask you to share with us, when you talk about outcomes, we're often used to reducing hospital admission, dying in blah, 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 those. Can you explain more about some rich and some different outcomes, outcomes with meaning?
I'm talking about patient outcomes and to some extent family outcomes. Family there being used as the broad term, whoever is close and important to the person. I don't care about the biology too much for this purpose. So for the person and those close to them. And so we've gone through a kind of rigorous process as a nation of agreeing, and we've had lots of carer involvement in this, agreeing a core outcome set. What are the things that we think are measuring? And it includes the things you would expect, actually. It includes, so if you're familiar with IPOS, it includes some of the items that are in IPOS. It includes some stuff about carer burden, some stuff about distress, some stuff about social functioning. Those are the things which, from the literature and from wide consultation with people with lived experience of caring for people with life-shortening illnesses, that we agreed as a nation would be important. And then we end up with a suite of tools. We just did the matching exercise to see which tools were capable of doing that, and it's IPOS and it's the 6-item Zarit. We had to get special permission from Mr. Zarit to use the unlicensed 6-item version because we didn't need the additional 6 items in the 12-item version, and it's really important that you don't overburden people with responses that you don't need. So we've kept it as slim as we can. And now, as I say, we're at the stage of having all of that grand stuff worked out, and all we need, crossing fingers, legs, everything else, is the digital architecture that actually makes it possible to do that with minimum friction and so on, so that you can use that output in your day-to-day care, and so that we can present that output back to the leaders of systems. I want the exec leads, I was telling Clare, I want the exec leads of each of the 7 health boards in Wales to be having a dashboard on their desk that lights up with what those outcomes are like for their population. I want them to know which symptoms we're not doing well at. I want them to know which non-symptom domains we're not doing well at. I want those data coming in not just for the people I see, because the people I see, I know what their outcomes are like. I've got their phone numbers, I can pick up the phone and ask them. That's easy. I want to know, and I want my system leaders to know what those outcomes are like for the people that we're not seeing. I want them to know what the outcomes are like for the people I discharged last month. I want to know what's happening. I'm a mainly community-facing doc, so I mean discharge from specialist follow-up altogether, and they're getting great care from the district nurse and their GP. I want the system to know what those outcomes are like, right, for the people we may be missing at the moment. And we're in a conversation about advanced and future care planning. I want those data being integrated with the output from FCP so we know it's actually improving those outcomes in that sense. And then we need the measurement of the experience as well for the patient and whoever's close to them.
So making a difference, not tick box. Jenny, I'm going to come on to you as well. So if you want me to remind you that broad general starter question, tell us more about planning ahead in your area, just to remind everybody. Scotland, obviously. What's the current state of play in Scotland and the key priorities for you?
Well, I was listening to everyone. I'm thinking, oh, maybe I'll move to Northern Ireland. It sounds like they've got a really great system in place. So I guess for Scotland at the moment, we are trying to get to that point, similar to what Ireland, Northern Ireland have, in terms of everyone on one plan, everyone sharing that plan. The kind of the staffing in Scotland, we move across different health boards quite regularly, and actually why then should a form suddenly look different, and then it's hard to work out what part you're trying to find or what part of the system. So we're doing a lot of work at the moment in terms of agreeing, shall we say, to one form that we will use across the whole of Scotland. But actually, our ambition for that is that we make it very broad and we do not focus just on kind of even the last years of someone's life. We want to know kind of all across the lifespan what is important to you at all ages, all stages. We heard from Vicky, which was so wonderful to hear about fee. And, you know, these situations can arise at any time. And it's so lovely that Fee had those conversations with you and your family, and it made the care easier to give because we knew what people wanted. So in Scotland, we're really focusing on what matters to you, and that can be broad, even if, you know, I don't know what is going to kill me. I don't know what treatments I might need or might not need. So actually, to decide right now whether I want a feeding tube, I've never had one before. I don't know whether I'd want it or not. But actually, I can say things like, I don't mind going into hospital if that's where the care can be provided. What I do mind is if there's any kind of power dynamics within my care team and I pick up on them, and that stresses me out. So I want everyone to be acknowledging of the fact that I will use dark humour to get through all of our awkward conversations, and that's more about who I am. Also, my sister needs to look after the cat, whether she likes it or not. So those are the things that are in my plan as a hopefully healthy 30-year-old, but as I grow, my plan will grow with me, and things might change, and these digital technologies can help us kind of keep up to date with that. So that's the main priority, getting something that works across the country and starting early.
Thank you. And I'm sort of, lots of people, you can see me smiling. You mentioned what matters most to you. Obviously, I've looked at all of your work, I've looked at our work, and even listening to Christian this morning. And I'd argue that what matters most to you theme, wherever we're working, that's something that I'm picking up is coming through from across the nations and internationally as well. And arguably the most simple question you can ask as part of advanced care planning. Plans will tumble and fall out of that question. Before I ask my next question of each of you, I'm just going to invite and thank everybody that's live streaming this as well. You're so much part of this conference. If you have questions for the panel, we are going to try and incorporate questions as well. So I'll be looking at you. I haven't got my glasses on, which is slightly scary, but do wave very wildly if questions are coming through. And we would invite you, and again, members of the audience as well. So I've got another question I'm going to be asking each of the panel members. People listening online and members in the audience, this is such a rich and valuable opportunity. If you've got a question, I'll try and keep my eyes out. And Danny, we'll share the microphone. It'll be fine. It'll be fine. So coming to each of you again, can you highlight a recent success or innovation in planning ahead from your nation that others might learn from? So we're all here to learn and value each other. And focusing with the growing emphasis on digital health, and we heard from Corrina and the impact of digital health in Northern Ireland as well. What role has technology played in planning ahead with you? I'd be interested to hear about digital record keeping specifically. I know from my practice what a challenge that is in creating those records, and then sharing those records. And any systems that you've got in place for sharing plans. Jenny, I'm going to come to you first this time. I know you've got lots of work in evolving digital technologies. Is there anything, what would you like to share with us today from that perspective, please?
So where I work is in Glasgow, so the west coast of Scotland, and about 6 years ago now, we created kind of our first image of what this future care plan would look like and how we would make it digital and how we'd make it accessible. And the main thing for us is that this should not be a medic-only form. So we are trying to make sure that the system can be inputted by a whole range of staff,
Unfortunately, we've not quite got to the point where also the public can straight away input into that system, but that's a work in progress. So actually, we want to hear from our care workers in the care homes who know their residents really, really well. They know what keeps them calm, how they like different things. We want to hear from them, and we want them to have that opportunity to input straight into the forms. We want our occupational health to be coming in. We want physios, OTs, speech and language therapists. Everyone should be able to add their part into this form, and in that way we're trying to kind of reduce the burden, so it's not one person who needs to fill out pages and pages and pages. We all put in our little paragraphs. We can even copy and paste them from our other notes and pop that into the form, and then the form can be shared again. So actually, it is much more beneficial for a district nurse who's suddenly got new people on their caseload or going out to visit them if they can look back and see, oh, you know, these people have been engaged with health for quite a while, but they've also got social care coming in, and oh, by the way, they've got a dog, and the dog will bark, but the minute you're through the door, will just like lick your face. That is probably going to start a better relationship than a district nurse arriving, hearing a very yappy dog and going, oh, right, okay, how am I going to deal with this? So trying to make the system as broad as possible. And in Glasgow, we've had quite a big success. We have lots of different staff inputting into the form, and it can get back out to the GPs, it can get back out to the ambulance crews, it can get back out to out of hours, and also a paper copy can be printed off if the people want it as well, so it's in their own files and it can be stayed at home. So that's where we're trying to, and hopefully that can then be replicated across the whole of Scotland as well.
Thank you. I've got a ghastly feeling we could do a whole conference on record sharing. I think that's, I know we could do a whole conference on those complexities. I'd like to come to you now, Idris, if I could. And through your specific lens, working in both statutory and voluntary sectors in Wales, I'd love to learn about innovation and technology and shared plans, sticking with that theme, particularly meeting that challenge that all of us, I think, will resonate with everybody in the room about sharing plans across boundaries and across multiple team settings.
And again, it's work in progress for us, and I would echo really the merits of what Jenny's described in Scotland. We're trying to do similar things. We have the advantage of having a single national data repository and a single clinical interface that clinicians across the voluntary sector in the hospice and palliative care world, as well as in the NHS in Wales, use. And that interface is close now to being able to host enough information about products of advanced and future care planning. I say enough because, of course, what we want to do is point clinicians to engagement with the person and those close to them, rather than making them just engage with a digital interface, but enough information about it that can support the immediate bits of decision making and can tell them where they can find more about what has come out of those conversations. Particularly, I think, harnessing some of the subtleties of the conversations. I don't know if Celia's still here. She and I have talked about this before. I don't quite share Celia's skepticism about that soft output from conversations that are about values and preferences, which then force clinicians to engage at the time and use that information to make the right decisions. I think we see very often best interest decisions being made very well using that nuanced information. So we're trying to make sure that that nuance is as available as our more binding decisions, specific refusals, and so on, so that clinicians can actually use those and use those well. And of course, if there are times when they're not using them well, then okay, we've got to go and tackle that. But we're just on the cusp, I think, of being able to do that. That interface, that portal, is the same interface that we will be using when we get the architecture in place to gather the outcomes data. And that's what allows then the integration, the data linkage, we hope for the future. I mean, we're not there yet. I don't want to give the impression we are, but this is this is the potential we see. This is the vision we have.
Would you like to write that vision on a pledge board out there?
I might just do that.
Thank you. And my head is racing ahead.
It's Clare up here. Got a question when you're ready.
Thank you. I'll come to Lucy, and thank you so much. So my question is racing ahead to thinking we'll follow up those words close and cusp as time goes on, potentially next year as well. It would be interesting to hear. So Lucy, you've got expertise in palliative care across a really wide range of settings, I know, hospices and the acute sector. So my same question coming back to you about what impact innovation and technology has played, and how do you share across boundaries where you work?
I mean, my clinical practice is very London-centric, and what is going quite well at the moment there is we've got the London Care Record and we've got the Universal Care Plan. And, I mean, it's certainly not perfect, but it does mean that when, all paramedics are able to see whether or not somebody's got a Universal Care Plan and to read it. And it's now normal, as far as I can see, when people go to hospital and they're in ED, the junior doctors or the nurses will be looking and noticing, because it's really obvious they've got a Universal Care Plan. You get a big red banner across the top. They don't always then go in and read the detail, but they do at least clock that they have one. And I think one of the, and I think that's relatively luxurious. And I'm enjoying it in the hospice because I don't have access to all of the NHS information, but I can access the London Care Record and I can see the Universal Care Plans there. So that is an example, I think, that is developing and seems quite positive. The issue is one of information governance and that care homes can't always access it. And then again, back to quality, which is that, paramedics tell me they don't bother sometimes looking at it because the quality is poor, and often when it comes to the medical emergency plans, it will say things like call the hospice, but actually what you want is what should I actually do right now when this person feels breathless? Can I just have an instruction about what medication is most useful or what techniques are helpful? So I think it comes back to the quality, but the tech is definitely growing. But I mean, expanding that to the whole country is just, I don't know. I mean, I know obviously we were all waiting with bated breath to hear what the government are going to suggest next, because then obviously digital and technology is a big part of that. So, maybe we're about to get something amazing that will do all of this for everywhere.
We will see. It is in there, isn't it? It's in writing, so we will see. It will be interesting to follow that up. Thank you so much, Lisa. I'm going to come now to the question, and who is it addressed to, please?
I've got two. I don't know if you've got time for both, or we start with the first one that came in, which is from Manchester Royal Infirmary. I think it is to all. Are you doing anything particular about advanced/future care planning for those that may face health inequalities, such as the homeless population or people who have a learning disability?
That's a great question. Sorry, I didn't catch the person's name.
Manchester Royal Infirmary.
Thank you, Manchester Royal Infirmary. So the question was about health inequalities and people with learning disabilities, if I heard correctly.
Homeless population or
and
people with learning
homelessness.
disabilities.
Thank you. And was it addressed to any one of the particular nations? So I'll do it broadly. Who would like to take that question? And interesting, that's one of the questions we discussed as well. So great question. Thank you, Manchester Royal Infirmary. Who would like to take that first?
Could I be really cheeky and nominate someone from the audience that I had a conversation with today, particularly about this? I see her sitting in the front row looking like, oh no. But yeah, I was wondering if you'd like to share anything. I can run and give you a microphone, or you can come up here.
Sue Marsden.
There we go. Run.
I'm having a very surreal experience here because Sue is absolutely fantastic and we go back very many years. I never thought we'd be sharing this stage when I had my cup of tea this morning. So Sue, you're an absolute expert and it'd be great to have your voice.
Thanks, Jenny. So we were just talking about learning disabilities. So I don't have a lot of experience from a homeless population point of view and advanced care planning. But I come here with a number of hats on. So one is that I'm a learning disability nurse by background. I am now a palliative care nurse as well, and I chair a small charity called the PCPLD, which acts solely to advocate for good end-of-life care for people with learning disabilities. But there are a couple of really nice new sets of resources and some really lovely bits of work that have been happening over the last couple of years. And so the main one is something called the Victoria and Stewart Project. It's so easy to Google, it's ridiculous. So you literally put in the Victoria and Stewart Project, and you will find a range of co-produced resources that have crossed from free, printable, downloadable resources, some of which are pictures, some of which are frameworks that you can then record people's wishes on. But then there's also some paid resources, so things like the books Beyond Words and talking mats, which help to guide and structure conversations about advanced care planning for people with learning disabilities. And this has all been co-produced with people with, to be fair, mild learning disabilities, because we recognise that the challenges for those who have more significant LDs is much more complex. And there's more work going on about how you engage people who have more significant learning disabilities. So I think the answer to the LD part of the question is there is work out there. The PCPLD network website has got loads of resources on it that you can have a look at. Some are free, some are website that you then download or you pay for. But the Victoria and Stewart project, yeah, I'd absolutely advocate. And then there's more work going on looking at good quality end-of-life care going forwards as well. I could just talk forever on this. I'm going to shut up now.
Thank you so much. So thank you for addressing one question, which is available to everybody here at the conference to access as well. So thank you for accessing that.
Justine's got something.
Justine.
Hi everyone, so my name is Justine. I work as part of the specialist palliative care team at the Norfolk and Norwich, and I just quickly wanted to mention an amazing project called No Barriers Here, which was started by the Mary Stevens Hospice based in the Midlands. Actually, I was born in the Mary Stevens Hospital in the Midlands, so it feels really close to my heart. But it's an amazing project. My colleague Mel and I were fortunate enough to attend one of their training sessions, and it's around kind of promoting ACP using arts and crafts for people with LD. So I just wanted to mention that as well.
So lots of resources.
Yeah,
for
wonderful
people to go
initiative.
away. Thank you so much. And anybody who's interested, I would also recommend the work of Dr. Naheed Dasani, who follow the work in the PEACH programme in Canada, particularly for people who are experiencing homelessness. And there's work going on in England as well. There's lots of work for research, for lived experience of people experiencing homelessness as well. We can put the links in resource for people. Idris, you wanted to come in as well.
If I may, I mean, and it's really great to hear those examples of good stuff being done. I don't have any examples like that to offer, but just a challenge to throw out, because when we think about the sort of founding ethical imperative for advanced care planning, future care planning, call it what we will, a lot of it is about making sure that people are given the opportunity for their voice to be heard and to influence decisions made in the future. That bit we all know and it's obvious. And if that's all we do, then we privilege the privileged. If that's all we do, then we give the opportunity for that to happen to the people who have had the opportunity or are going to have the opportunity to express some views and preferences, and that's people like us in this room. And yet the question, and I think it's such a great question from Manchester about inequalities. What we have to do in response to that same ethical imperative is go looking for the people who haven't hitherto and won't, if we don't, have the opportunity to participate in that way. We've got to go looking. It's not something you can do to people, but it is something where it's desperately important as part of the wider care, as we've each talked about, desperately important that we go looking for the ways, and it can be challenging, but you've got great examples of ways actually to facilitate that participation for the people who otherwise lack it. So I'm chucking out a sort of ethical moral gauntlet as you're thinking in each of the places where you work about how you implement some of this stuff.
Thank you. And it's great to put down challenges as well and sort of shake us out of assumptions as we're talking about advanced care planning. Lucy, I know we've heard from members of the audience as well. Anything specific to answer Manchester?
I mean, well, what it was making me think about is, of course, what does advanced care planning actually mean in the context of people who don't necessarily have capacity to make these decisions themselves, and more of just a thought, really. It's obviously the most common cause of death is now becoming frailty and dementia, and so many people that are, certainly in hospitals where advanced care planning is initiated are actually not necessarily in a position or may have a limited ability to participate in these conversations. And I suppose it's just a point of caution that we have to think about what is actually being documented and whose preferences are they, how have they been captured, is this sort of a formal best interests discussion that's taken place, has a capacity assessment taken place. So I suppose it's just making me think in both context of learning disabilities and dementia that it's challenging, and we must be careful. And I was going to say something else, but it has escaped me, so don't worry.
Would you like to borrow my pen? Because it'll come to you when somebody else is talking. You got your notepad there. Thank you. Was there a second? I've got another question for the panel, but we're happy to take... It's great to hear people feeding in and to hear. So is there another... I've got...
There is another one online.
And then I've got somebody in the audience as well. So
Do you want to do this one then?
Yes.
Okay, yeah. This is from an anonymous attendee, so I don't know who it is. Given that large proportions of our most vulnerable population in care settings are still not being routinely offered the opportunity to engage in advanced future care planning, what action is the Care Inspectorate in the panel's respective countries taking to ensure that this becomes a standard, supported part of person-centred care across all providers?
Great question there. So if I heard correctly, given that most vulnerable people are currently not offered advanced future care planning, are there any initiatives? It really leads on from what we were talking about before. I don't know, Idris, I'm sure you got some... Lucy, you look like you're poised there.
It's actually, well, it's brought back what I was thinking
Excellent.
of before. So I was just thinking about the role of social care, and that, of course, I'm a doctor, so where I see advanced care planning initiatives usually in medical settings, but actually there's not everybody, we would think about when we're identifying people that would benefit from the opportunity to participate in advanced care planning, and actually social care is a place that has a lot of opportunity, because obviously as people's health is declining or their function is declining, they're more likely to need care. So it's so important that we're working cross-boundary and it's not just health-focused. And I suppose that's where I was going to, obviously thinking of the gold standards framework, which is a cross-boundary program specifically aimed at empowering frontline professionals to identify people who might need advanced care planning and then carry that out. So
thank you. Jenny.
So I will frantically try and remember the order of which these words come, but we have frameworks for our care homes, and I want to say my care, my home, my life, but it might change around those words if you're Googling. And within that, there is the kind of duty, I guess, of all care homes to have future care planning for any of their residents. So they do get audited on that, and the Care Inspectorate do pick up on that. Touching on what Lucy was saying about the difficulty then of care homes then being able to get back into the system and share those plans. So, and also an understanding of what we mean in the quality of the plans, because actually when someone is living in a care home and that is their life and that is their home, there will be lots of bits and pieces of information that they need to kind of communicate to other people so that we know, their preferences in terms of personal care or how they like to eat food. Or my mum is adamant that she will never play a game of bingo in her life, so it's really important that she doesn't get dragged into activity rooms to go and play bingo. And that is actually really important, and some of that information does need to be then translated to hospital if that's where she ends up. Particularly, again, don't drag her in to play bingo. But also, I understand that the kind of headlines, the things in bold, the things that need to be really easily accessed by clinicians in certain times of crisis might be different. And I think that's where we all have a duty to work together to get things digitalised, because then different parts of that information can be pulled down into different views that suit the team and the kind of time when that can be accessed. But then we can go back and we can get that rich understanding of who these people are. So I think Care Inspectorate absolutely play a really crucial role in holding people to account and saying, actually, have we given people the opportunity to tell us about it, and whatever way they want to tell us about it. But then also, as staff, we have a duty to then make sure that's recorded into a system which can then be accessed by a lot of people. And that goes for whether you're working with LD communities, whether you're working in homelessness. Maybe actually their priority is not the final few days of their life. Maybe their priorities is about, where it is in the city that they're based and the community that they have and the support networks that they have. And we don't want to kind of then take them somewhere else out of that comfort zone. So it's really important that we get that sense of who these people are and then record it in systems that can be shared. So yeah, I think great question.
Thank you. Idris, I think you've touched on this with vulnerabilities and accessing as well. Would you like to build on
Yeah,
those
I mean,
themes?
just one brief thing, because of course none of the information sharing and digitization and all the rest of it is going to address that question if people are not first having the opportunity to participate in this stuff. So a part of what we're trying to do, and what I would certainly be arguing for, is normalizing that curiosity that makes sure that we take steps to find out what matters to people. And it's so much what we've talked about, but normalizing that so that it's no longer normal not to do that, whether you're in a care home setting or whatever health or social care setting or in communities, just trying to normalize that curiosity that says, right, I don't care whether anybody calls it FCP or not, we can come to that later, we can come to the paperwork later, we can come to the forms. You've got to be normalizing that curiosity that finds out what is it that's important to someone, as well as the kind of clinical stuff or the details of their social care needs, normalizing that curiosity.
So what I'm hearing is normalising quality and its discussions, not forms. So regardless of where we're working, I think we're chiming with those themes as well. I'm very mindful of time. We've got about 3 minutes left. What I was going to do is take one question and then we'll do a sharp closing question as well. So I'd love to come to a member, and thank you for your patience as well. I know you've been waiting some time. So could we have your question? Is it directed to any particular member of our panel?
It's not really a question, it's an observation, because as Jenny was speaking then, you've sort of answered it a little bit. I work as an Admiral Dementia nurse specialist, so advanced care planning is a big part of my job. To me, it's a personalised plan. So that can be written, presented in whatever way that person sees as appropriate. So I suppose it's like a caution, really, when we talk about digitalising, can't get that word out, these plans, is that we're very, very careful not to take it out of that person's hands, because otherwise, I've been nursing a long, long time, worked in community care and hospital. Sometimes we can be a bit gung-ho and we start taking away that responsibility from that person, and that plan won't be theirs anymore. It'll be a number of sort of hospital or medical or social members of staff filling in bits of that plan without taking the focus away from the person. So that's just really...
Can I jump in on that? I mean, I couldn't agree more. The place of the digital sphere is to point us back to the person.
Yeah.
Now, you need the digital work. You need the digital work to be able to do that, because if you don't have the paramedic at 2 a.m, knowing that there is some information to be found, then the information is lost. You may as well. You've wasted the effort. You've wasted that person's time. Worst of all, in gathering the information that cannot then be deployed. But that is the role of the digital: is to point us back to the person.
Okay, so it's not going to be like a huge document that everyone will. It'll be actually this person's got an advanced care plan.
The detail is work in progress, as I say, but that's got to be the ethos. That's got to be the purpose.
I love that phrase of pointing back to the person. I'm looking at the clock. I've got a ghastly feeling we've got about 1 to 2 minutes left for our panel discussion, glancing at Danny here as well. I've got a feeling we could have this discussion over 2 hours. I would encourage everybody here to continue this discussion. All of our panel members are available and accessible social media. You're all available social media as well. So let's continue having these conversations and challenging each other as well. I've got one closing question, and my challenge to you is I'm going to come to each of you with the same question, and to close us within 1 minute. So a short, brief answer. I'd really value your thoughts. If we were stood here, as hopefully we will be, Danny, in 5 years' time, if you're sitting here on the stage, what headline change would you hope to see in advanced care planning in your nation? Lucy?
I would like it to be not about death, but about life. And I found Christian's talk this morning very inspiring and very in tune to thoughts I've been having. But we so often, these types of events, not today, it's very much all sort of emotive music, and it's all about dying, and it's so sad. But we're alive, until we've finished. And what I would really hope is that it will have a more positive sort of wellness vibe to it. So this is actually just seen as people taking control of their lives, living well until the end, instead of it all being so sort of doom, gloom, avoid it, because it's all about dying.
Excellent, lovely. Thank you so much. Somebody saw me do a high five there. What a lovely as well. Jenny, I'll come to you. I'm literally going in order. What would you like to see in 5 years' time?
Well, I mean, Lucy's kind of exactly what Lucy was saying. I think I'd like to see these conversations not as a one-off, as a lifelong conversation. So we revisit it every time we have a cup of tea. We, something comes on the news and that might develop thoughts, or something happens in your community and that changes your mind. And so it's an ever-evolving conversation. That's what I would like these to be seen as, and that is really what life is about. Life evolves, and yes, okay, at some point it will end, and we might need to have conversations about how it might end, but actually, what are you doing in the day-to-day, and how do we make sure that you can live well in the day-to-day? So I think that would be my hope.
Thank you. Another lovely key and positive message. Idris, your closing message.
I mean, it would be, if I'm still doing this job, or whoever my successor is, to be able to look you in the eye, or look the health minister in the eye, and say, we know that this is being done in the way we've talked about. So that person-centred, pointing us back to the person, that the opportunity to do that is being made equally. Again, picking up on some of those questions, and that we've got the outcomes and experience data to show that that's actually being done in a way which is making people feel better, giving better outcomes and experience, not just making us feel better, and good enough data linkage and integrated data collection actually to back that claim up.
Lovely messages. So life, not death, the conversations, and proving the quality with the data and evidence behind it. So I'd like you to join me with a huge round of applause for our fabulous guests, Idris, Jenny and Lucy.